you doing?
Yeah, I'm there, very much there.
Yes, I can see you are there and relaxing.
Acha, it's you. I thought it's Jason. How are you? Yeah, good.
Okay, start.
Good evening, everybody, and welcome to another exciting episode of Pediatric Potpourri by Indian Academy of Pediatrics Cochin branch in association with the Kerala State branch. We have a very interesting topic today, tuberculosis, and with us we have experts in the field, renowned, and I welcome all you again. And over to Dr. Jason for further proceedings. Thank you.
Welcome again to the Pediatric Potpourri, and this time we've arranged pediatric pulmonary tuberculosis for you. And as Dr. Pramod Warrior has already mentioned, it's we're going to dissect this in and out. As we have always said, we are each program that we're doing is going to the heights of academics in that particular topic. And that's what we're going to intend to do today. We will start off with, I'm going to introduce our one and only Dr. Varinder Singh. So he's going to be moderating this whole session. And oh, he's gone. What happened there? Are you seeing the slide?
No, yeah, there it is.
Yeah, Dr. Varinder Singh needs no introduction at all. He is the director, professor of pediatrics, and the lead in the National Center for Excellence for Pediatric TB. This has been recognized. The center has been recognized as the National Center for Excellence for Pediatric TB under the National TB Elimination Program, and he is the professor and director at the Lady Hardinge Medical College in Delhi. Well, his special interests are so many, and he's mainly tuberculosis is his forte. Interventional bronchoscopy. He's an author of several papers and books. He's a lead in the NTG of pediatric TB, invited expert for preparation of the guidelines in asthma, TB, respiratory infections in children, and he's a past president of IPA Respiratory Chapter, president of the Asian Pediatric Pulmonology Society. He's done his MD and FRC PCH honorary. He's a Commonwealth Academic Staff Fellow of the Pediatric Respiratory Medicine, European Diplomat of the Pediatric Respiratory Medicine, and the Asian Diplomat of the Pediatric Respiratory Medicine. Over to you, Dr. Varinder Singh, and he's going to give an overview of pediatric pulmonary tuberculosis for you today. Dr. Varinder Singh, please share your slides. How we're going to go about this is a case scenario, which Dr. Srikanta will be going through, and at each stage there'll be a discussion about that particular case at that point of time. And that's how we're going to go about this whole session. Dr. Varinder Singh will initially give an overview of pulmonary tuberculosis. Dr. Varinder, are you sharing your slides? Has he gone off? Pramod, is Dr. Varinder Singh out? Oh no, where's Dr. Varinder?
Can someone call him up?
Can call him. I think he's Pramod. Somebody should go off for him to get in. Yeah, what happened? My gosh, 1 second. Pramod. He got disconnected and can't enter. Oh, problem.
But I see only 97 participants here.
You can request one of them to exit and then, let him enter.
He's got, Dr. Marinder has got out of the thing and can't enter. Just I'll call him again. You can enter. There's only, we have cut off 3 or 4. So try and enter again. It's the same link. It says maximum 100 participants already there. Try again later.
No, sir. Only 94 in the meeting.
No, but it says that. So what do you do?
Sir, there are only 94 people in the meeting.
No, there are only 94 in the meeting. No, you go out of Zoom and come. No, you completely get off Zoom and do it again. You will have to get somebody out. Oh, this is we go out.
So what is he using? Any particular?
Oh no. Now what happened? He's getting the same message. I think we should, some of us should come off. Pramod,
Yes, sir.
can some of our IAP Cochin branch people move out to something? He's not able to get in.
So there are only 89 people now. Oh, okay. Now I can see him.
Yeah, he's come. Now you're in. Now you're in. I can see you. Yeah, come. Okay. Share your slides then.
Yeah, I'll do.
Okay, so welcome, Dr. Marinder. I hope none of you get out of the anymore, huh? Because getting in will be tough. Okay, so now it's filling up again. Now we got the full.
My apologies, but not because of me. It's just the technology. It fails you when you expect it to work.
Yeah, it's a.
So, do you think we should start, or should we wait for people to join?
No, start. Everybody's in. Start.
Okay, fine. So thank you, IIP Kerala and IIP Kochi, in particular, Dr. Onni, for inviting me. When we talk of pediatric TB in today's time, things have changed. Routinely, conventionally, what we were doing, looking at characteristic symptoms and then look at skin test, radiology, and small bits we were doing in microbiological confirmation. And as we go up, as the specificity increases, the sensitivity was obviously coming down. So this was a situation where we were largely using conventional tools some of bacteriology with a ZN smear. Cultures were available, but remotely would come in about 8 to 12 weeks, were not used. So most cases were clinically diagnosed. Definitive diagnosis was usually not attempted because one, pediatric TB is being possibacillary, there was very poor sensitivity of the smear and very limited availability of culture. And even if it was available, there was a long lab turnaround time in weeks. So we presume that all new cases were drug sensitive because 90-95% of the initial cases are drug sensitive. And we would work up for a drug resistance only if the child had high risk of resistance. Now, things have changed. This would often lead to a delay in diagnosis of drug resistant TB, and which would lead to a risk of amplification of resistance because you were using standard therapy for drugs for everyone. And if the child had by chance a drug resistance, then you were amplifying it. So TB diagnosis therefore needs to be more efficient. It has to be now more often microbiological with a rapid detection of the resistance which is always bugging us or most difficult to handle, that's rifampicin. And now we are also realizing that INS resistance is also, which is another big bull in the China shop. This desire of the profession where you wanted to have culture or know what the sensitivity of the organism was before treating as you would like for any other bacterial disease was fulfilled by availability of rapid molecular tests, which made it easier and better as compared to the past. So that has changed the whole goalpost from an MTB detection to actually upfront knowing MTB as well as whether it is sensitive to rifampicin. So that's what is the essential change today, and that has shifted the goalpost to totally as to how we would use the investigative algorithms for diagnosing pediatric TB. So there has been a strategic shift where you are using more often approved rapid molecular tests. The standard genes being guided by universal drug sensitivity are now being used. What do we mean by a universal drug sensitivity? Universal refers to all cases being tested upfront from drug resistance to rifampicin at least. And it does not mean testing for all the drugs. So universal is for patient cohort and not for universally for all drugs. So that's an important difference. Why are we focusing on rifampicin? Because your first line drugs, which are most effective, would totally fail if there is rifampicin resistance. Not only that, it will augment the resistance to other first line drugs. So you want to take away a rifampicin resistance group, which needs a different set of treatment, and continue with the rest of the group with the standard first line regimens. That's the strategic shift we have. Why rifampicin makes a priority? As I said, one, it is difficult to treat. Two, resistance to rifampicin is more easily detectable because most of the cases are restricted to the mutation in one gene, which is beta RPO. And these genes, the most mutations, more than 96% of the mutations are known. And therefore, it is easy to identify rifampicin resistance as compared to other drugs where the mechanisms may be multifold, and therefore it may not be a single gene, and you have to all the mutation pathways are not known. And this is a key drug, and we also know how we can detect it, and therefore that is why TB diagnostics have evolved to use rifampicin to begin with. So if today's time would come, the pyramid of TB diagnostic would have changed. You would start with characteristic symptoms, conventional radiology, maybe some bit of tuberculin skin test, to converge all this into identify cases who require microbiological confirmation. That means the base of the pyramid is teasing out what looks like TB but is not TB. And when you know it is likely to be TB, you are confirming, establishing it is TB using a microbiological test, which not only tells you it is TB, but also tells you whether there is rifampicin resistance. So the pyramid has changed. Therefore, the algorithm has changed. Therefore, the way we would use these things would be different. Today, we have a very interesting case set up by Dr. Shrikanta from Bangalore, and we will follow the journey of this patient to learn about TB diagnostic, pulmonary TB diagnosis. So this patient will help us learn all the nuances of pediatric TB diagnostics. So that's all from my side at the moment. Thank you.
Thank you so much, Dr. Varinder. We will now go on to the case presentation, and that will be done by Dr. Srikanta. Srikanta, please share your slides. Now, this is the case that we're going to discuss right through all of today. And this is going to be presented by Dr. Srikanta JT. He is done his DSCH and DNB. He's a clinical fellow in pediatrics, pulmonology, and sleep medicine from Singapore. I think under Dr. Mahesh Babu, isn't it, Dr. Mahesh Babu?
Yes.
Intervention bronchoscopy from Italy, and he's now working at Apollo Specialty Hospital, Bangalore. And it's currently the Intervention Pediatric Pulmonology and Sleep Medicine Institute of Pulmonology, Apollo Hospitals, Bangalore. He also visits Aster CMI.
Yes, sir. Yes, sir.
And he also comes once in a month to Aster MedCity, Cochin, where I work. And he's got a lot of publications to his credit. He's a young pulmonologist, one of the few in the country is doing EBUS. And he's got a lot of experience in EBUS. And therefore, we will listen to what he's going to say and take us through this case. Thank you, Dr. Srikanta. Please carry on.
Thanks a lot, sir. So today we'll be sharing a few, one case about pulmonary tuberculosis. And I'll be taking through the journey of this particular case because this was a very difficult journey for the child because child had a lot of symptoms. So starting with the case, 8-year-old school-going child presented with complaints of persistent fever and dry cough for 3 weeks, was evaluated elsewhere for persistent fever as POO with investigations, and at the same time initially treated with oral antibiotics and then started on IV monosef. And this child was
Audio not there. Srikanta?
Srikanta has lost connectivity, perhaps.
What's happening today?
My God. Oh, he's there. I can see him, but oh, he'll also have. Will he have
Maybe it is
difficulty?
just a poor, network at that moment. So
No, Jason,
Yeah.
can if you have that slides, I think I will anyway have to discuss the first half.
Srikanta, what happened?
3-4 slides are there till X-ray. If you can.
Srikanta, what happened? What happened? Oh, you don't have an. Are you still in? He's got a power cut there.
Oh my God.
I think Jason, do you have the slides?
No, this is what I said. I wanted all your slides.
Okay, I'll try. I'll see if I have got.
but even if we'll get slides, we can't get Srikanta in.
No, we'll get men.
The PowerPoint has evolved, but not as much. The speaker doesn't work in.
Oh my gosh, this is the.
Don't worry, Jason, will come back. It's just a test of time.
But again, sir, 100 are in.
So you can't get in?
There are only 95 people are there. We have space. Don't worry.
Yeah, he's getting in. He's getting in. Today's been one bad scene.
Sometimes it just challenges you. It's okay. Not your fault.
Jason, I have forwarded the slides to you. One of you can share. Srikanta slides. Sarji, Parinder sir, with your permission, can I present the same case for till 7-8 slides instead of keeping mum, if you don't mind?
Why should I mind? It's totally.
No, sir, I'm just taking consensus. Vijay Evle sir, please.
I have no problems at all. You're welcome to do that.
Because these are first few slides only. I think after my presentation, he can join back again when the.
Yeah, please go ahead.
Yeah. So, Jason, you can be in, and I will present on behalf of Srikanta this case. This is, everybody is fine?
Yeah.
Okay. So, an 8-year-old school-going child presented to Srikanta with a fever of 3 weeks and a dry cough of 3 weeks, was evaluated elsewhere for PUO before it came to him, and there are a lot of investigations worked up for fever. And you can imagine if there is 3 weeks of fever and cough, they would have done many tests. And
the slide is
Slides are not seen.
Slides are not seen.
No.
Again, I will share. Is it seen now?
Yes.
Put it full screen.
Yeah. Is that fine?
Huh?
Now is it fine?
Yes. The slides are seen.
Fine. So he was treated with oral antibiotics initially for fever and cough of prolonged duration, and was given antibiotics orally as well as injectable ceftriaxone. And when he was presented to him, the child was febrile and was not having tachypnea, hemodynamically stable. There was minimal pallor, and there was no significant lymphadenopathy elsewhere. And height and weight were relatively fine as per the IAP growth chart. And systemic examination otherwise was fine. So fairly we have got a child who has fever and comfortable, minimal pallor, but the duration of fever is pretty prolonged. That was the challenge, with lot of investigation bundled with him, which is going to unfold now.
You're in, no?
When he came,
Hello?
the investigations which done outside.
You're in, no?
Yes, sir. Yes, sir.
Srikanta,
Please come in. Okay.
I will browse the slides. You can present.
Right, sir. So,
Yeah,
So investigation done outside, CBC with ESR, elevated WBC with neutrophilia, and a normal ESR. Rest of the initial blood investigations, including the Montu test, MP by QBC, Vidal, Leptospira, IgM, scrub typhus were normal, which is usually done for less than 2 weeks of fever. Induced sputum for AAB into 2 samples, and a gene expert was done, which was negative. HIV was done because of persistence of fever beyond 2 to 3 weeks. And a bone marrow was done as usual, which showed hypercellular marrow, hypercellular as well as normal marrow, and a culture sensitivity which had no growth. The next slide, sir. So this is the chest X-ray that was presented to us, and this was the chest X-ray which had a little bit of mediastinal widening. I wouldn't say little, there was a significant mediastinal widening, what we can see here. And there was a little bit of collapse, consolidation kind of a feature in the right middle lobe medial segment. Apart from that, most of the other parts of the lungs looks reasonably normal. So I would want Dr. Subramania to take over from here.
प्रतिमा टेस्ट झाली ना त्याची?
Jason sir, you have to unmute.
Yeah. So we're going to have this presentation by Dr. Subramania. I think the first slide, please. First slide. Subramania is, now he's going to discuss the algorithm for the management of, for the diagnosis of pulmonary tuberculosis. Now we have this child who has presented as a PUO, and all the investigations for PUO were negative. We only have some mediastinal widening and some shadow on the right side of the lung, right low mid zone, and therefore the case will be now discussed further by Dr. Subramaniam. Please share your slides, Dr. Subramaniam.
Yeah.
Yeah.
Yeah, I'm going to do that.
Yeah, so he's going to say, is it TB? Your next slide, please make it slideshow. Yeah, the next slide. And this is Dr. Subramaniam. He's looking much better in this photograph. He's the professor of Vaidehi Institute of Medical Sciences, Bangalore. He's honorary secretary of the IAP National Respiratory Chapter, and you find a lot of these programs that he's doing on the web. He's an executive member of the IAP Vice President of the Respiratory Chapter, Karnataka, and organizing secretary of Respicon 2017, a huge show in Bangalore. And he's had a number of publications to his credit. The very, very enthusiastic speaker, very humorous. He's a very nice, is a gentleman to the core. Welcome you, Dr. Subramania, to present on the algorithms for the management of diagnosis.
Thank you very much, Jason, and my colleagues and friends across Kochi. I still remember our past president, Dr. Sachidanand Kamath, and many seniors, Dr. Sukumar and others from Ramesh from Kerala, and also my friends across the country who are viewing. And first of all, let me tell you, we have two seniors over here, Dr. Vijay Avle and Dr. Varinder Singh. And first of all, let me confess and tell you, kudos to the way they have worked upon disease tuberculosis to its core. Hats off to you, sir. With your permission, I am going ahead with the discussion.
Please.
The case so far has been that it has stopped at X-ray. This is a child which had prolonged fever, and investigations for fever did not give any clue. This child has associated cough, and this X-ray was somehow, as per Dr. Srikanta's words, had some doubts about mediastinal widening, has some concerns about mid-zone. But is this enough? See, look here, this child has been given oral antibiotics as well as intravenous antibiotics. They have done everything that's possible. Still this child is not responding. At least the fever is not responding. And what next? So basically we need to understand, whenever we have problems in cases like this, should we go on investigating or should we come back to history and look at symptoms? You know, the old mantra tells us that we should come back to symptoms and analyze them properly. In this child, we have a symptomatology. We have essentially normal physical examination. That means that was not giving any clues whatsoever to the source of fever. Investigations either, which have been done so far, did not give any clues to the cause of fever or source of infection whatsoever that we were looking for. And the good old Mantu has not helped us. It is pretty normal. Chest X-ray is giving some hints and clues, you know, to see if we can do something about it further. And what's the next step? Now, I will go stepwise. Let's look at symptomatology in this child. We have 32 symptoms, but I've just mentioned for completion. If there are any other symptoms, we need to explore again. Essentially, this child had fever, cough, and we always, and there are many postgraduates who are watching this. Please, many of my patients also, they tell fever of 8 days. When they get admitted in the hospital, there is no fever. Have you seen this in practice? Please remember, is it just that the head is warm? Is there a documented fever? Somebody at least once or twice have recorded the fever. This makes it very sensible, that because many investigations which are going to unfold are really invasive, and therefore we should not go wrong anywhere. So we need to have a documented fever and at least once of more than 38 degrees centigrade. And I think in this child we had one. Srikanta, you would agree with me. Yeah. Secondly, this fever is persistent. What do you mean by persistent fever? So I'll tell you, many mothers tell me, sir, whole of July he had fever. The irony is that on 1st of July and on 31st of July there was fever. And they will tell us that the whole month was febrile. You know, see, please understand, when we say persistent, please ask them day-wise. Was there Monday fever, Tuesday fever, Wednesday fever? I'm sorry for this detailed interview, but as students, you need to ask them, does this child have persistent fever? And by simple means, we may not be able to explain the cause of fever. You know, it remains little bit unexplained. So we have a setting where in this particular child, I'll presume that this fever was persistent, unexplained, and well recorded and documented at least once to make sure that this child is febrile. And number two, what about the cough in this child? See, remember, most often in practice we see recurrent coughs, and they should not be mistaken for tuberculosis. Always we must ensure that the cough is persistent, not recurrent. What we mean by persistent cough is the cough starts, cough remains, and cough continues. Please understand, somebody says I had very high cough, too much of cough on the phase of resolution of illness, acute viral illness, for example, and then, you know, cough is there, not gone, but it is reduced. So if the cough shows a declining trend, that's what I'm referring to by trend. If the cough increases a bit but shows a trend of decline, that means it is an acute self-resolving cough because of oversensitivity of the cough receptors inside the airways, and this is very common in practice, and therefore we should be very careful. Otherwise, you will making overdiagnosis of tuberculosis or whatever the disease in question. So we need to even identify the type and nature of the cough to make sure that we are dot on target. So in this child, we have persistent, unexplained, prolonged fever, persistent, unremitting cough of around 3 weeks duration. And there are a couple of other symptoms which are important, but I don't know how much was reliability as far the parents are concerned. Many parents will tell that he has fever and he has lost weight, he has become thin. And this is very, very important for us to make sure that there is a proper recording of the weight and documented weight loss. Because do not go by the perceptions of the mother, because all mothers, I'm telling you in my practice, even the mother of an obese child tells me my child is not eating well. And therefore, when we are referring to non-specific symptoms, we should be very careful. And lastly, we must elicit the history of contact. And when I say contacts, we will not get into glossaries of contact, because I will tell you contact only means that who has given the disease to the child. So to that extent, we must be able to elicit if it is in the household, we need to get the contact who is a recent contact. And what we mean by the recent contact is he should be having tuberculosis within at least 2 years from the symptomatology that we are referring to. So a 2 years duration is taken as general cutoff. The reason is simple. See, if you get an infection, you may or may not get a disease. And if you get a disease, you are going to give the disease to the others. If you just get infected, and if you are not throwing out the bacilli, you may or may not give that bacilli to others. So therefore, remember that for somebody to give from an infection conversion to a disease is maximum in first 2 years of infection. He can theoretically be infectious throughout, but unless suppose a treatment intervention happens, the untreated case I'm talking about. So therefore, somebody getting a disease would be highly infectious in first couple of years, and therefore that makes it logical to know, is there somebody in contact? Now, for the postgraduates, not having contact history will not take out the thought of tuberculosis from your mind, for simple reason. A child may not have anybody with contact in at home. How do you know a school teacher is not having? How do you know his friends are not having? Is it that the child doesn't visit a temple, park? So therefore, a bus, school bus. So we never know, a driver, for example. So we will never know who is the source, and therefore, if you have a contact, it's well and good. If you don't have a contact, please do not assume that he doesn't have contacted with tuberculosis. I think fairly has sensitized students as well as the practicing pediatricians as to how you should come back to symptomatology and make sure that these 3 pillars are very, very solid for you, because when you move out of this, you can't come back again. So in this child, we had fever, yes, cough, yes, and other symptomatology like weight loss and other things, no. So this child is something like suspect TB. We are not using that word suspect TB nowadays. And so we now got a terminology called as, this case fits into the definition of a presumptive tuberculosis. So presumptive tuberculosis with some investigations doesn't qualify for anti-tubercular therapy. That's exactly what we are going to unfold in this case. Let's see. So first part of the algorithm, we just don't need symptoms. We need symptom characterization. And that's exactly what I mean by qualified symptoms. And do we have in this child? We have fever. We have cough of 3 weeks duration, more than 2 weeks. We have enough. So can we suspect TB in this child? See, I will tell you, I'll come back to this case more. You know, we had a child with fever and cough, and other than that little bit of cough, we had no clue whatsoever for fever. We have given antibiotics. We have done many investigations which came negative. So therefore, is this a suspect TB? Answer is yes. So this is a suspect TB. What do we do next? I think this child was a presumptive TB, and therefore most often we do these 2 common tests. I don't know if you go by algorithm or not, you go by your reflexes. We end up doing these 2 tests, and many of us will do these 2 tests, chest X-ray and MANTU. This has been done in this child. MANTU is negative, and chest X-ray has been shown to you for waiting for discussion, and that's why I gave you this little bit of background. What next? Chest X-ray showing some clue, plus minus. What to do next? Next is this is the step where many of us get stuck. We will not know. Sir, MANTU is positive. Is this TB? And at least I got 25 to 30 WhatsApp messages. Plus, please explain about MANTU testing. I will tell you, I will not explain about MANTU testing. Stop doing MANTU testing. And MANTU testing has its advantages and disadvantages. So don't be carried away by indirect tests. Mantu, if at all, can give you evidence of infection, may or may not tell you the disease, and therefore chest X-ray and Mantu test suffice here for me to tell you they are indirect tests, not direct tests of proving a bacilli, and they are very, very popular. You know, it's very difficult to take out the popularity from these two tests. Right now, given these two tests, I would prefer that a chest X-ray is a must. Whether Mantu is must or not, I think it gets unfolded as we move further. I think Dr. Varinder Singh nicely pointed out that the essential part of diagnosis of tuberculosis is microbiological diagnosis. And microbiological diagnosis is the only thing that confirms tuberculosis. And I tell you, it doesn't just confirm tuberculosis, it gives sensitivity to the sensitivity of the mycobacterium to the drugs. And this is the most important essential part before we start anti-tubercular therapy to any child. So please, rifampicin is a very good drug, one of the fantastic drugs for tuberculosis, and knowing the sensitivity of rifampicin is the cornerstone for starting the therapy, and therefore we must make sure that today the diagnosis of TB is, sir, this is a case of proven TB. No. This is a case of proven rifampicin sensitive TB. This is where we want you to come in, and that's very, very important. And a small tip for the students and the practitioners. You must draw a Lakshman Rekha. What we mean by Lakshman Rekha is, you do get history and symptoms. You do Mantu test, I agree. You do chest X-ray, wait. You have to go beyond these three and cross Lakshman Rekha and establish microbiological diagnosis, which could be sputum, which could be histopathology, it could be, you know, nucleic acid amplification tests, which we are going to talk, and they are wonderful. Until and unless you do them, you are not going to start anti-tubercular drugs. And I think this message has to be re-emphasized, and that's the beauty of the modern approach to the diagnosis of tuberculosis. And I tell you, you know, you go up to this every time I see you and you need to just do a little more. You know, this is the way in which the flow of or sequence of our evaluation goes in tuberculosis. And Dr. Varinder Singh nicely told that you need to get specificity higher. See, microbiological diagnosis has high specificity, and chest X-ray has low specificity compared to that. And therefore, until unless you go for a very specific and a confirmatory test, you cannot start the treatment. On the contrary, you know, the indirect tests are very sensitive. And you know, infection is more than a disease, and therefore you can get a Mantu positivity more than a confirmation, isn't it? So therefore, the tests lower down in the pyramid are more sensitive, but higher up are less sensitive. And I'll tell you, if you look at the cost, as you climb up the pyramid, the expense goes high. Maybe it's free now at all the government centers, but I will tell you, even the government needs to spend for the test. And therefore, whenever you are doing more confirmatory and specific tests, which are going to make some cost some money, you need to pass through this journey and be very careful that you don't stop and complete the journey. And that's the message from this particular case. So in this case, we have symptomatology and gone up to chest X-ray. And let me give you a couple of tips as far as X-ray is concerned. Is X-ray good? We have, sir, you may tell me, sir, so far, before all these newer diagnostic modalities have come, we have made diagnosis only on X-ray, and were we wrong? The point which I wanted to tell you is that the X-ray is no doubt good, is quite sensitive, and but the specificity is relatively poor. See, if it's around 60% for tuberculosis and as well as for other diseases. So what does that mean? So therefore, it's like 50-50, you know, it could be this way or that way, and sensitivity is good. So that means you should start with an X-ray, not stop at X-ray. That's exactly the message as far as tuberculosis is concerned. So in the X-ray, should I look for a node or a parenchyma? So the simple thing is, in children, lymph nodes, you know, if you take lymph nodes as a spectrum, children are the ones who will have maximum presentation of lymph nodes, and in adults, the chances of you getting a lymph node from an X-ray is around 40%. And on the similar lines, is it going to be a parenchymal disease or not? Less than 3 years, 50% of them will have parenchymal disease. I mean to say a predominant lung involvement. But as the age advances, you will have more and more parenchymal involvement, and in adolescent you can almost get an adult type of pulmonary tuberculosis. These are the hints for me. So whenever you are looking at an X-ray, please look at the age of the child. It may not be just a thumb rule, not a rule, but just to get an idea of evolution of the disease, and that makes you very, very comfortable. Please learn how to interpret chest X-ray. And a couple of days back, I have taken 1.5 hour session on webinar on how to interpret a chest X-ray. And those of you who want, I will send you the link. There is a recorded webinar, and you can go through how to interpret chest X-rays, and therefore I'm not telling more about interpretation of chest X-ray. But the point is that you will have overdiagnosis and underdiagnosis from chest X-ray. This is the caution I want to tell you. If you look at the specificity, and therefore if we give X-rays to 100 pediatricians to make confirmed cases of TB, let's say, ask them, could it have been tuberculosis retrospectively? I will tell 50 will tell yes and 50 will say no. What does that mean to me? So should we ask interpretation of X-ray or just tries a coin? Head means tuberculosis, no means no tuberculosis. If the interpretation comes to around 50%, it is head or tail situation. So therefore, it's very, very important for us to get it right, get into appropriate way of interpretation of X-rays. It is not the fault of the X-rays. You need to be correct on technique. You need to be correct on exposure. It should be a good inspiratory film, preferably a PA film than an AP film. And you must always see in front of a screen. I'm sorry for telling all these basics, but none of them are followed in practice. You can have, suppose if you take an X-ray, chest X-ray, we have an X-ray now. We can have 4 types of an X-ray that comes to us. One, it could be highly suggestive of TB. It's not suggestive, but a non-specific finding, say consolidation, so on and so forth. It could be inconclusive, calling for a repeat X-ray or further, no, don't rely on the X-ray and do something else. It could be a normal X-ray, but variants are there. And I think you get into the module of tuberculosis where they will also teach you what are the variants, an expiratory film, a film that is rotated, mistaken lymph nodes, so on and so forth. And I think it's very, very important for you to understand the variants of normal, confluent shadows, this, that, etc. So it's very, very important for you. Please make yourself familiar with variants of normal in a chest X-ray so that you don't make a overdiagnosis of tuberculosis. Let's see what are the highly suggestive X-rays. I'm not going to teach you X-rays here. We have an X-ray here and we'll straight away go to the case. All that I wanted to tell you is that look here, the first one to your left shows a miliary shadow. Then you are damn sure that probably, not all miliary, but at least in a given symptomatology, you are almost near to tuberculosis. Highly suggestive. If you have a cavity, especially thick-walled cavities. If you have thin-walled cavities, it could be congenital cysts and so on and so forth. But if at all you have a thick-walled cavity, it's more likely to be tubercular. And if you have a kinking of airways, compression effects, localized emphysema, difference in the right and left lung, all these points. And if you have a lateral, you can see a donut sign. I'm not showing you all the variants, but the last X-ray I'm showing you is, you may not have a textbook description of a suggestive X-ray, and it could be very subtle compression of the trachea and all. So in paratracheal area and all, so or a carinal angle for that, widening for that matter. So you have to be familiar with all these presentations before you would look into X-rays. What about Mantoux test? I'm not going to spend more than 30 seconds on this slide because it's very, very important. Most of us get into more problems after doing Mantoux test. So please understand that you have 4 categories here. True positive, that will tell you only infection. True negative, that means that the child doesn't have been exposed to tubercle bacilli or its antigens. False positive, you can get falsely positive in children who have atypical bacteria, recently vaccinated with BCG, so on and so forth. False negative, that means you have a tubercular disease, but it comes negative. It can happen in miliary, tuberculosis in SAM children, undernourished, let's say HIV. So you can have negative MAN2 but yet tuberculosis. So therefore, do not be carried away by MAN2. If at all it comes positive, it is only suggestive of infection, not necessarily disease, but you have to prove the disease. So again, it comes to tossing the coin as far as MAN2 is considered. So therefore, we have to do molecular diagnosis as far as tuberculosis is considered, and that is required because we need to also get rifampicin sensitivity before we start the treatment. So we have CBNAT, and you will have wonderful discussion on CBNAT in the slides to come. I'm going to just make a passing remark. This has revolutionized our approach, diagnostic value to the tuberculosis. You have better versions on CBNAT. CBNAT is not all that good, means you have more sensitive CBNAT, that is CBNAT Ultra, and we have a true NAT that is indigenously prepared by Indians, and it is going to come in future for you. And therefore, I come back to this case. Have we gone classically in approaching this case with a nice algorithmic approach? See, this is the first step of algorithm. Fever of 2 weeks duration, unremitting cough, plus or minus weight loss. Are we there? Yes. Initial screening X-ray chest. Have we done? No, first of all, is it a presumptive TB? Answer is yes. I have defended very well. No other disease because you have a cough and a fever. Setting is there. Now I have done the X-ray. Chest X-ray, is it suggestive? There was a quite doubtful mediastinal widening and some right mid zone. See, it may not be highly suggestive. It is, you can take it as non-specific. Okay, mediastinal widening, if you can see very good widening, then it is highly suggestive. Suppose you have doubtful plus minus mediastinal widening, you are not very confident of a lymph node. It does happen. Children don't walk with textbook descriptions, and at times you may have a suggestive but not highly suggestive. You have to go further. You cannot stop here. You have to demonstrate the positivity on a NAT test, and either a sputum, gastric lavage, or induced sputum with gastric lavage is the best state of art, and you have to do this because I will give an example. You can take a pleural effusion for that matter. Sir, should we do a pleural tap CBNAT or should we do gastric lavage in that particular child? You should do gastric lavage. Even in those cases, there will be bacilli in the airways and you can get it. So therefore, never ever go back on this tip. It's highly recommended, highly sensitive. It is very specific, and upfront it gives rifampicin resistance, and it's available in hours. It's very, very important for us to do this test. So confirm, suppose it comes positive, you are going to check at rifampicin sensitivity and start treatment. Now, I am coming to this child as per the algorithm. NAT is negative. Does it mean no TB and I have to look at other causes of fever? Should I repeat malaria, this, that? That's the question. So I'll go further. NAT negative does not rule out tuberculosis. It is sensitive, but it is not final. You can miss even on CBNAT, and therefore, I'll tell you, if you take culture versus NAT, culture yields better than NAT, and that's very, very important for us to understand. So therefore, please remember that the yield of the culture is on overall 40 to 50%, and NAT is much less than that. And if I give you the comparison of CBNAT with the old smears that we were demonstration of AFB, which you are all reading in most of the old textbooks. So sputum in NAT is sensitive to the tune of picking up of 90%, and smear is only 30%. So it's 3 or 4 times better than the old conventional methods that we were going for. And look at the yield from the gastric lavage. It's almost more than twice that of from the smear. So this is very, very important message for all of us. So therefore, in this child, we have done this also, and that has come negative. So what we should do now? That's when he showed me the X-ray. So please look for alternative sites for somewhere I can get some material for CBNAT. or for culture. So you please re-examine the child. You might have missed a node, or look at the mediastinal node itself closely and evaluate further. Or you may look for better quality specimens which give higher yield. For example, if I do a lymph node aspirate, what's just a gastric lavage? Don't you think lymph node, if there is a lymphadenopathy, lymph node aspirate would give a better yield? Suppose a misparenchymal disease is there, and you do a bronchoalveolar lavage. As there is a non-specific shadow and a collapse segment or a consolidated segment, and you do BAL from there, can the yield be better? Probably better, isn't it? So therefore, these are the tests that needs to be done. So therefore, at this point of time, given that X-ray, if I were to be in periphery, I would refer this child to a higher center where these things can be done. What I meant was at least a bronchoalveolar lavage or a lymph node aspirate. I mean, which means that we need to go for more invasive modes in this particular child. So still negative in a higher center. What you will do, sir? You look for alternative diagnosis. If you are very sure no other alternative diagnosis center type, you can rarely diagnose a clinically diagnosed tuberculosis, and I will tell you this should be a desperate and last diagnosis, not the first diagnosis. In that case, you have to report to RNTCP authorities, and should be that state of art center, and with a confidence not to empirically start ATT at all. In this particular child, this is a very, very highly exceptional situation and a rare situation. So I'm coming back to this case. I'm almost coming to end of my discussion. So in this case, we have done chest X-ray. Should I repeat sputum? Probably I may not get. So I will look for alternative sites. I will recheck the contact. Sometimes they won't come in. I will call all of them and see. Simple means sputum and somebody is having cavity. Then we are done. Look for an extrapulmonary site. So therefore, in pulmonary, I won't go too much into extrapulmonary at this stage, but I have just kept it as a part of algorithm. Please consider bronchoscopy plus or minus CT scan in this child, because the sensitivity of CT scan compared to a chest X-ray is double. CT scan picks up twice the case which an X-ray can pick up. And I tell you why. Because there at least half of the lung is hidden. The area of the lung, retrocardiac, behind the ribs, beneath the liver, above the level of clavicles. I tell you, if you read the textbooks of radiology, there are many hidden areas of lung, and your interpretation may be wrong. So therefore, CT scan is twice a better mode than an X-ray. But you may ask me a question, sir, what about radiation? I will tell you the current CT scan machines are high generation, and in a quick time they will finish off the scan. There is a software that can give you HRCT. You don't have to write for HRCT. Please understand the point. So therefore, do not worry. I'm not highly recommending, please, from tomorrow, for every X-ray that comes negative, don't go on doing CT scan. But you should have a reason and justification for doing CT scan. In that case, do not worry. It can pick up cavities that have been missed on an X-ray. It can pick up lymph nodes, because in X-ray, the mediastinum is a graveyard. You can pick up on a scan, and especially in children with PUO, when you do not know anything, somewhere you can get some source, and therefore you must have little bit high sensitivity for ordering a scan. And in areas where we have a facility like Srikanta could do here a bronchoscopy. So lastly, I will come back to this case. I think this is a case where I would go for a CT scan plus or minus bronchoscopy, and I gave full justification as to why I would do this in algorithm. Over to Srikanta, what did you do further? Did you do a bronchoscopy and CT? If so, please let me know how did this case unfolded further. This is where I would refer to you and keep quiet. And this is what as a pediatrician I would do. And over to you, Srikanta, for further case flow.
Sure, sir.
Go forward with the case. We're going to do this case in a bit by bit.
Right. So coming back to the case scenario, a wonderful presentation by Dr. Subramania regarding how to go forward with this particular case. So again, going back to this chest X-ray, there is mediastinal widening. This is the 8-year-old. Thymic shadows are seldom seen in these children. So there is mediastinal widening, and there's a little bit of collapse in the right middle lobe medial segment. So we went ahead, according to the flowchart that Dr. Subramania presented, we went ahead with a CT thorax. CT thorax, you could see there is significant burden of disease in terms of mediastinal lymph nodes. The right paratracheal, the subcarinal nodes are all quite significantly swollen. It's difficult to describe about the necrosis in this particular CT, but there were a few areas of necrosis, and we went ahead with bronchoscopy as well as endobronchial ultrasound and transbronchial needle aspiration. And endobronchial ultrasound is similar to a bronchoscopy. We have a convex probe at the tip of the bronchoscope, and that convex probe also has a working channel which will let us visualize the lymph node, and we puncture the lymph node under the vision, and we also see the blood vessels when we do that. So we were able to puncture paratracheal, subcarinal nodes, and we also get proper core biopsies just to make sure we don't miss out on lymphomas in these cases. So at that particular juncture, it was not only tuberculosis, we also had lymphoma as one of the differentials, as well as Hodgkin's lymphoma, T-cell lymphoblastic lymphoma as other differential. And that is the reason why we went ahead with biopsies. And as expected, and as Dr. Subramania told, AAB smear was positive, gene expert was positive, Recurrent is sensitive, started on ATT with good improvement in clinical symptoms and reduction, and MGIT grew MTB within 2 weeks of the management. So I would ask Dr. Jason to take over for the next one.
Jason, you need to unmute. Please unmute, Jason.
Confirmed case of tuberculosis. Confirmed case of tuberculosis because we've gone the full mile to make the diagnosis. Now we'll go and see what the current recommendations for pulmonary tuberculosis is, and I invite Dr. Vijay Evla to give us. He's been on the board for RNTCP, and we'd like to have him to tell us about the treatment recommendations. Can you have the next slide, please, Vijay?
Yeah.
Vijay is the director of the Dr. Vijay Multi-Specialty Hospital for Children in Navi Mumbai. He was also in ICH Apollo Hospital, Navi Mumbai. He was our IAP president in 2014 and is the editor of Pediatric Infectious Disease Journal and the IAP ID Chapter Journal. Over to you, Vijay, for your presentation on the treatment of pulmonary tuberculosis.
Hello, everyone, and thank you, Jason, for giving me this. Yeah.
This picture is more like what you are at heart. Different here.
Thank you.
Sorry, please go on.
Yeah, thank you so much. Jason, thank you so much for giving me this opportunity to be present amongst so many of fellows from Kerala and maybe from other parts of the country. And I'm extremely happy to be, sharing this faculty dais along with my guru mentor, Dr. Varinder Singh. And I mean, very nicely presented by Subramaniam, and he laid quite a bit of emphasis on how must one go about working up a case of tuberculosis. And then again, before I start with actual treatment, I would like to reiterate that starting on a when you enter an algorithm, unless your starting point is very solid, you are likely to falter. So make sure that you work up a case based on a very solid, firm, presumptive TB diagnosis. And then not uncommonly, we do come across cases where, like in this case, X-ray was asked for, and X-ray has been moved up in the algorithm. If you all remember the previous algorithm, just because X-ray gives you the clue and further direction. Here you had a child where it was a presumptive TB based on the symptomatology, and X-ray though was not classically suggestive of highly suggestive of TB, but it did show mediastinal widening and some infiltrate, and that is what made Srikanta work up further. And though Subramaniam shared only part of algorithm, I'm sure Dr. Varinder in the end would run through the algorithm for the benefit of PG students and all other viewers, and we'll discuss how does one go about when the picture doesn't really fit in well with the tuberculosis. Having said that, here you have a patient who has finally been diagnosed microbiologically as a case of tuberculosis based on the EBUS done, and the lymph node tissue grew. It detected made a molecular diagnosis of TB and detected the AFB. And midget culture also in due course of time grew bacilli. So the first and foremost step that one must do is you must document complete diagnosis. And what do I mean by that? You must write down all the details, type of patient. Here we have, it's a newly diagnosed patient. Details are required. We know that this is a pulmonary TB and it is primary complex based on the mediastinal lymph node involvement. And the basis of diagnosis in this case has been a mediastinal lymph node aspirate proving to be CBNR positive. And as we have been discussing all along, this is a test which gives you rifampicin resistance upfront, and we did not detect any rifampicin resistance upfront in this child, and that means this child perhaps is a sensitive, drug sensitive tuberculosis. And then you must jot down the treatment plan, which is, I have written here 2 HRSAD plus 4 HRE, meaning thereby you give intensive phase with 4 drugs and continue 3 drugs in the continuation phase. I will elaborate on it a little bit as we move along the presentation. And one most important thing is TB is a notifiable disease, and one must notify all the cases to the National Tuberculosis Elimination Program. Second thing is HIV testing is a must in all cases where you make a diagnosis of tuberculosis. This child was worked up for HIV in the beginning itself, given the history of prolonged fever, and so one must make note of this also. And as I said, one must notify this case to the program, and one could do it on the portal NICSHI. And there are different ways in which one can notify tuberculosis. You can report by the toll-free number that is there on the screen. Those who are not yet well versed with this, please note down this number. You could also report on the portal, or there is a mobile app. You download the app, register yourself, and start reporting cases whenever you come across a case of tuberculosis. And then one could also just contact the local TB center, and there are agents who liaise between the private practitioner and the program, and they could collect the data, and this is how you would report all the cases of confirmed tuberculosis to NICSHI. The advantage why one must report is, one, it's a national tuberculosis elimination program, and all of us are, I'm sure, are aware that we are committed to eliminating tuberculosis 5 years ahead of the global commitment, and program is doing a lot. And so we need also to take a step towards joining hands with the program and go all out and leave no efforts unturned, no stone unturned to supplement the program so as to eliminate the tuberculosis. Secondly, once the patient is registered with the program, provided you register with all the details and submit the Aadhaar card, the patient derives a lot of benefit from the program. The account of the patient is deposited with rupees 500 every month towards the nutrition, improving the nutrition of these children. And there is this happens throughout the duration of treatment. So the child is on treatment for 6 months. Every month he gets 500 rupees. And 500 rupees for a child, most of these children come from a low socioeconomic strata, is an important incentive, and the nutrition can really be looked into with this benefit. Not only the patient, but even the private provider who looks after the child suffering from tuberculosis is given incentives so as to improve the notification. Today there is a huge gap between the real burden of tuberculosis and what is notified to the program. And so private provider gets about 500 rupees on notification and 500 rupees on reporting treatment outcome, because it is extremely important to know the progress and the outcome of treatment, so that we do not miss out on treatment failures or defaulters. And one big advantage of having notified this child to the program is the program people take care of, they ensure that the child adheres to the treatment, and there is no faltering in the treatment, and treatment is completed as recommended. So the next step would be to start, plan the treatment. And I'm sure in the past there were 3 categories, then we moved on to 2 categories, and today, as per the revised guidelines and recommendation, all the cases, whether pulmonary or extrapulmonary, whether confirmed or probable, once they are diagnosed first time, they are put in one category. And even those who are previously treated and who have failed treatment, or who have defaulted and restarted treatment, are put under this category, and they are started on drug sensitive TB medication. But these patients who have had diagnosis in the past who did not, who failed the treatment are upfront worked up for drug-resistant tuberculosis. So all in all, we have only one category now, and there is a reason behind this. In the past, the intensive phase was extended. Sometimes only inadequate number of drugs were added, and what was realized in a systematic review, or that the success of therapy in the erstwhile category 2 was only 60 to 80%, and especially those who failed treatment did not do well at all. And keeping in this mind, the category 2 has been eliminated, and now all the patients are put in category 1, including those who failed treatment. They are but worked up for drug-resistant TB, and I'm sure Dr. Varinder will touch upon this during his presentation on drug-resistant TB. Then exposing this potential or suspected drug-resistant TB definitely led to amplification of resistance, given the presence of INH resistance that we have in our country. We have in the range of about 12 to 13% primary INH resistance, and resistance coming on treatment is much higher. So we have this one category where you have new microbiologically confirmed pulmonary TB, which is rifampin sensitive, new clinically diagnosed pulmonary TB, new microbiologically confirmed extrapulmonary TB, new clinically diagnosed extrapulmonary TB. And as Dr. Varinder Singh walks you through the complete algorithm, we will talk about what we mean by probable TB, where treatment can be initiated on empiric ground, and then finally you have drug sensitive previously treated TB, but with the caveat that you would work up these patients for a drug resistant TB. The treatment essentially involves two phases. One is intensive phase and the second is continuation phase. We use 4 drugs in the intensive phase, and that is done so as to quickly reduce the infectivity of the given lesion, and prevent death and deterioration in the given patient. And continuation phase is done with the aim to eliminate the residual bacilli and prevent failure or relapse. These are a few conditions in our practice where combination therapy, like your falciparum malaria or road traffic accident, where you are justified, and in fact it is warranted to use more than one drug. And for the benefit of PG students, let me remind you that when you have a colony of TB bacilli, you have mixed population. There are a few which are dividing very rapidly, so rapidly multiplying bacilli. A few are intracellular, a few are extracellular, which grow a little slow. And you have different drugs acting on different kinds of population. On the rapidly multiplying, you have the isoniazid acting the best, followed by streptomycin, then you have rifampicin, and then finally ethambutol, in that order. The intracellular bacteria, bacilli, are best taken care of by pyrazinamide. And it is thanks to pyrazinamide that we have been able to truncate the therapy to 6 months as compared to what it used to be in the past. So pyrazinamide has really made it possible to cut short the duration therapy to 6 months. And then you have extracellular slow growers where rifampicin and INH would and ethambutol would work better. And then ethambutol is something which is, as compared to what was not done in the past, is used as an additional drug in the continuation phase. Why was ethambutol added in continuation phase? I told you, on the background of INH resistance that we have in our country, imagine a child who is having rifampicin sensitive tuberculosis is started on treatment, and if happens to have INH resistance, what would be left in the continuation phase would be only rifampicin, because given the INH resistance, INH would not work. So with that thing in mind, a third drug is added to continuation phase. So now continuation phase is HRE, which is followed all over the country. The intermittent therapy has now been discontinued, and every child is given daily therapy. And this we have talked about that systematic reviews. In INH resistance, there was a risk of failure ranging from 9 to 45%, especially in children who were given only H and R. And it was documented that if you add a third drug, the relapse rate is, and the failure is definitely brought down. One must also remember that looking into the pharmacokinetics and dynamics of the anti-TB drug, the doses have been revised upwards. If you remember, those practitioners who are in practice for last over a decade, the INH was given in the dose of 5 mg per kg in the past. but all the drug doses have been revised upwards. Now it has a range: rifampicin 10 to 20, INS 7 to 15, pyrazina 30 to 40, ethambutol 15 to 25, and septomycin 15 to 20. And the average milligram per kg per day dose is mentioned in this table. And remember, there is a ceiling dose for every medicine that you use. This ready recommended table is available on the government site, and those who have attended the TB module, I'm sure they must be well versed with this table. It is always advisable to use fixed drug formulation so that adherence is better and it's easy to administer. There are two types of formulation available. I'm mentioning adult formulation also here because children who are weighing more than 40 kg, they would require adult type of formulation. Now, if you look at this details of this formulation, pediatric formulation has two parts. One combination tablet comprises of isoniazid, rifampicin, and pyrazinamide in 10, 15, and 20 ratio, whereas ethambutol is a separately packed tablet because ethambutol is not a dispersible tablet. It is said that in near future, one is likely to have a combination of all the four medications. As against that, you have adult formulation with the doses mentioned on this slide, and then it's easy to practice depending on the weight. You have a weight range, and you move up or down the band depending on the child, how the weight progresses as the child starts responding to the treatment. So you have this easy to remember weight bands and the number of combination of fixed drug formulation that a child needs. For example, a child between 12 and 15 kg would require 3 of the pediatric tablet with 3 ethambutol tablet, whereas a child who is say between 30 and 39 would require 2 of pediatric fixed dose combination and 2 ethambutol plus 2 of adult tablets, so on and so forth. And as I said before, we have discontinued intermittent therapy because intermittent therapy was based on the principle that the doubling time of TB bacilli is about 21 days, and one could, target and aim all the medication on twice or thrice a week. And but the problem in that, even if the child missed out on one dose, it would leave behind a big gap, and there was always a potential opportunity for the TB bacilli to multiply. And the final change that has been made now is addition of pyridoxine. Pyridoxine is supplemented in all patients with tuberculosis, those who are put on isoniazid, whether it is for treatment or for prophylaxis. This is done because the neuropathy associated with INH because of competitive metabolic block is accentuated, especially in children who are malnourished, which most of these tuberculosis children are. And given the fact that INH dose has been revised upward, and also in children, at times it becomes difficult to recognize and pick up this neuropathy early in illness. And given these facts, a decision has been made to supplement pyridoxine to all these children. And no baseline LFT is recommended by the guidelines which are derived, which we have arrived at by consensus between the Indian Academy of Pediatric TB Working Group and the National Tuberculosis Elimination Program. So friends, this is all that I had to talk about the treatment recommendation, and this is how this 8-year-old child who has confirmed tuberculosis, microbiologically confirmed, with rifampicin resistance not being detected, classified as drug sensitive TB, and started on 4 anti-TB drug. And I'm sure Shrikanta would tell us further what the midget grew. Midget is a liquid culture where the turnaround time is much shorter as compared to your solid culture, and that's a big aid in confirming the diagnosis, one, and secondly, it also gives you an opportunity to test for sensitivity, phenotypic sensitivity to the given anti-TB medicine. And before I close, I would like to reiterate again what Dr. Subramaniam said, that though CBNAT has revolutionized anti-TB therapy, sensitivity that he mentioned was, when you test, there has to be a gold standard to compare with. So those who are culture positive specimens, there the sensitivity of CBNAT is much higher as compared to your conventional TB smear. But still you have a huge chunk of culture negative pediatric TB, where even CBNAT can be negative. So remember friends, a negative CBNAT does not rule out tuberculosis. It's a good rule-in test, but it does not rule out tuberculosis. So I think I will stop here, Jason. I'll stop sharing my screen, and over to you, Jason. Thank you so much.
Thank you so much. We had two excellent talks by Dr. Subramania and Dr. Vijay Evile. I think most of you would have enjoyed listening to the state-of-the-art management of pulmonary tuberculosis still so far. Now, Srikant has gone on with this case. This child, I think, is the story is not over. So, over to Dr. Srikanta for the next phase of this child's case.
So, this particular child was followed up and was doing reasonably well.
Please.
So this child was followed up and was doing reasonably well. And that comes to the next talk, which is what to check for on follow-up. So this is what I'll be talking about. And the objectives for the day will be monitor and record the response treatment and decide on actions to take in response to monitoring results, manage unanticipated clinical progression, detect and manage adverse reactions, and manage treatment interruptions. So these are the broad the objectives that we are going to talk to you about. So I think this is what RNTCP card looks. This is downloaded from the NTEP 2020, and we do not see the 4 month follow-ups, the 4 month follow-up for category A and category 1, and the 3 month and 5 month follow-up for category 2. So here we just have pre-treatment, end of IP and extended IP, which is not done currently, 2 month in CP and end of treatment. So these things have been taken off now and probably will be updated in the coming updation. Apart from that, we also have the disease classification of pulmonary, extrapulmonary, date of date, month and year when the treatment was started, the type, new patient, relapse, treatment after default. So most of these are going to be updated according to the current classification guidelines. And this is what the treatment card looks like, where we have pulmonary, extrapulmonary, type of patient, the month when it was started, when the sputum examination is supposed to be done, what is the particular patient's smear result at each particular juncture, patient weight. Again, reiterating, the extended IP and extended the end of IP and extended IP are not there. Only extended end of IP is there and end of CP is there. And the going forward, this is going to be modified so in clinical practice and according to NTEM 2020, what do we look for? Correct evaluation of a patient, site and severity of a disease, and compliant treatment. One can anticipate clinical radiological improvement over a standard time frame. I think most of us or most of people who have treated tuberculosis will know this particular fact. First follow-up at around 15 days to reevaluate dose as well as combination and adverse effects, if any. It can be a patient who has been enrolled into NTEM currently, or it can be a private patient. So always reevaluate the dose, always look at the combination of the medications that your patient is taking. Patient
No audio.
No audio.
Again,
I think we have
power failure again.
No audio. Srikanta.
Power failure, sir.
Power failure, I think. Jason, you can go ahead.
Someone take over.
No, the slides are with you.
No, I don't have the
Only I have slides up to X-rays.
Oh, this is sad.
No, at least sir can start.
Start what?
See,
I
think
don't have these slides, so I can't. I can maybe in the meantime share the rest of the algorithm if that's okay, Dr. Jason.
Please.
my God.
Okay, friends, technology has been truly playing truant today, so don't worry. We will try to beat it as much as we can on its own game. So my friend Dr. Subramania had taken you through these presumptive cases who are gave you all the clinical characteristics. And then he said the initial screening is X-ray chest. And then he took us through whether it is suggestive or non-suggestive X-ray. What is the difference between a suggestive and a non-suggestive X-ray? There is no footprint on the X-ray chest which is diagnostic of TB. Even the most suggestive, like miliary tuberculosis, like lymph node hilar or mediastinal, or a chronic fibrocavitary, thick or thin cavity, which is chronic by virtue of the history, that it's a prolonged history, is something which is suggestive. Because if you were in America, the same X-ray with a cavity or a lymph node would be histoplasmosis. Even a miliary which does not respond is not necessarily MDR TB. It can also be Langerhans cell histiocytosis. So these are suggestive, not diagnostic. That's one thing to remember. The other thing we learned was that it's not enough to know it is TB. You also need to know, as was very nicely explained also by my friend Dr. Vijay Yeble, that today we need to know whether it is a rifampicin resistance carrying bacteria or a non-rifampicin resistant carrying bacteria, because only the first line therapy is used when you are rifampicin sensitive. So therefore, even if it is a suggestive TB, in the past the things would have ended here. Today they don't. You go ahead, do molecular test and see whether it is positive or negative. Suppose it is negative, one could be that the specimen quality was poor, so you could do it with a better quality specimen. Or it could be that it's a persistent pneumonia where you need to go further. You could use alternative specimens like or you could look for alternative sites, because about 30% of the time when you have pulmonary TB, you also have alternative extrapulmonary site involvement, particularly peripheral lymph node, which is amenable to a needle aspiration and can be tested by the same test, which is NAT, either a true NAT or gene expert or expert rif. If you run into a situation where you have radiological shadows and symptoms, and all of this is negative, then you have to seek help from a center which is more experienced, that you are not missing an alternative diagnosis. If you are not missing an alternative diagnosis, then you can treat it as a clinically diagnosed probable TB. Now, this does not mean that every child has to undergo a CT or every child has to undergo a bronchoscopy. To the extent possible, if you are not able to make a confirmed diagnosis, that you are not able to, there are pointers like this miliary tuberculosis who has a skin rash which is eczematous or seborrhea and also has got hepatosplenomegaly and some thrombocytopenia, I would be worried about Langerhans histiocytosis. So this is a picture. The other clues, softer clues, which will tell you that alternative diagnosis may be relevant. So your extent of pursuing this molecular diagnosis beyond or sending this patient for more detailed investigation depends on how strongly is the possibility of an alternative diagnosis. The other situation may be the non-specific shadows. Suppose if we had not agreed, I'm getting a call from Jason. Yes, Jason. Yes, mine are moving. No, as yet it is not animated fully. So if you have non-specific shadows, then there is a course of, you may have to give course of appropriate antibiotic. Non-specific shadows means a collapse or a consolidation. This child has a right middle lobe collapse, or you have inhomogeneous opacities. This could very well be an atypical pneumonia. So you give appropriate antibiotic. Skip this test if the child has already received an appropriate antibiotic course. And if you have persistent shadow, then you go ahead and do a NAT. So in the past, we would write X-ray chest and smear in the same breath, because smear was much cheaper, but then it was harder to get a GA. So now we say you screen with X-ray chest. Dr. Subramania said that the CT is about twice sensitive. I'm not sure about that because I would say if you are thinking of a persistent PUO or a persistent pneumonia, pneumonia should show an X-ray test. A PUO, an X-ray test is normal. You are definitely within your rights. It's a cost-benefit ratio is in the favor. If it is not mimic, if you have alternative diagnosis ruled out, you're looking for a hidden area of involvement, CT is maintained. Immunocompromised, CT should be done. In a persistent pneumonia, which is not resolving and all your initial tests have gone back, then CT may have a limited role. But remember, friends, even with the most latest CT, you cannot identify an MTB. It just still gives you another set of shadows, which have another set of differential, which will be sorted out only by a microbiological diagnosis. So CT has a definite role, but CT is not the solution for everything. Often, if we can't read an X-ray, we aren't sure of what X-ray is showing, we order a CT. It will give you more details. It may not give you a diagnosis. The third situation could be that you have got nothing on the X-ray, but this is a child who has all the symptoms. This is a child where you should also look for extrapulmonary TB. So this is a child you investigating for alternative causes, hidden areas, extrapulmonary TB, and that's what we mean by referring to a higher center. You may be the center which is a higher center for you. A higher center for you is not necessarily the topmost hospital in the city. Higher center is any center which has the capacity to do more than what you are able to do and interpret it. Often we think, oh, this investigation I can get done from outside. Can you interpret it? Can you take it further? Otherwise, believe in shared care. Let somebody else diagnose, you handhold this patient to completion. And that's something which benefits both. It's win-win situation for both for the patient and for the doctor. So this is what is the algorithm for pulmonary TB. Is Shrikanta back?
Sir, till then, can I ask a doubt for you, if you don't mind, sir?
No, I don't mind at all. Why do you think I don't mind anything?
No, if you get a situation of atypical pneumonia as a persistent pneumonia diagnosis, are we justified in using azithromycin, which is also having anti-tubercular action? I think you got my point.
The atypical features of pneumonia come if it is chronic or partially treated. So your course of appropriate antibiotic is relevant. Suppose someone was given, this shadow did not improve and was given cefixime, which is a very commonly used antibiotic, which is very poorly active against strep pneumonia. Then there's no need for calling this as an atypical pneumonia. You use appropriate antibiotic, it's a chronic case, you may use azithromycin in those situations. Azithromycin has very little activity against Mycobacterium tuberculosis. It is more effective against NTM. So it doesn't matter, figure into this. So the recommended antibiotic by the group and worldwide, including WHO, is amoxicillin or comoxicillin. That's what we recommend. Again, the situations or in an individual case, what was received earlier, how much was the response would also decide. Because remember, here we are discussing TB. So we are saying if the shadows do not resolve, give an appropriate antibiotic which has non-TB effect. But we also have to remember a non-resolving pneumonia is a whole gamut of diagnosis, including TB, wherein many other antibiotics will come into play. I hope you get your answer.
Yeah. Thank you, sir.
Can I continue?
Yeah. Somebody wants to ask a question, or is it Shrikanta?
Shrikanta is back. So can you please stop sharing your screen so that we can go back to the case?
I would. I'm glad he's back. Shrikanta, hold on to that PAR now.
It's not in my hands.
PAR, not electricity, the PAR.
Yes.
Power.
So I was just extremely sorry to everybody because there's been significant power interruptions here. So just going forward, correct evaluation of a type of patient, site and severity of disease and compliant treatment, one can anticipate clinical and radiological improvement over a standard time frame. The first follow-up at around 15 days to reevaluate dose, combination and adverse effects, if any, has to be done, which usually is done at the DOTS level at only 1 month, not at 15 days. But Patients usually come back to you. They usually show the DOTS medication if they are using, or you would have prescribed the combination medications that the patient would get back to you, and always ask for adverse effects if there are any. Post that, they're usually followed up monthly during both intensive and continuation phase. And currently, the recommended is, as most of them are regular patients and most of them know that they have to follow up, a regular follow-up has to be reinforced at 6 months, 12 months, 18 months, and 24 months post-treatment. That is, even after completing treatment, these patients have to be followed up for until up to 24 months. So going by, so monthly follow-up. So we've done a follow-up at 15 days. We've looked at the dose. We looked at the combination of the medication, and we've also looked at the adverse effects. If there are none, so we ask them to come back every month during the intensive phase as well as the continuation phase. And during every follow-up, and we have to look at the appropriate therapy, reevaluate the dose as well as combination, look and ask for adverse effects, if any, reinforce compliance, motivate completion of therapy at every visit. That is a very, very, very important thing that as a pediatrician, we need to tell the patients, because within a month's time or within 6 weeks' time, patient feels better, patient starts having zero symptoms, appetite is extremely good. If the patient had loss of weight, patient has gained weight, suddenly they think, no, everything is gone away. Unless you do not reinforce compliance and motivate them, usually treatment falters or treatment interruptions do happen. Document any missed doses and dosing according to the weight. So if a child has lost, say, 7 kilos or 8 kilos or more than 5% of body weight during the disease period, once you start them on ATT, we usually see them gain a reasonable amount of weight at a particular period of time. So unless you do not readjust the doses at that particular juncture, again, you will be underdosing them, and this can definitely lead to a lot of significant problems later on. And we also look at response to therapy. And response to therapy, we have clinical. So symptoms monitored are fever, cough, loss of weight, loss of appetite, and other symptoms. We have microbiological response to therapy as well as radiological response to therapy. Again, reiterating, appropriate therapy has to be done every month, and response to therapy is looked into as we go on. So response to therapy, clinical, fever starts reducing usually by end of 2 weeks, and they usually have a defervescence by end of 4 weeks. We seldom see patients or children coming back to us with persistent fever beyond 4 weeks. Yes, we do see a few patients, but in a confirmed TB case, if you see persistent fever spikes, if you see persistent clinical symptoms, you start thinking about other possibilities. Cough, again, depending on location of TB, can take longer. That is endobronchial tuberculosis because of significant, there are multiple varieties of endobronchial TB, and depending on the type of endobronchial TB, you can have cough which can persist a little longer, that is more than 4 weeks. And again, if these are present and if you are very comfortable with the diagnosis and you have all the microbiological samples to tell them this is a particular diagnosis, you can tell them that this will get better. You just need to follow up a bit more frequently. Weight, children often do not lose significant weight, which is a very, very important thing. So if we tell patients, no, your child is will start gaining weight significantly after the starting of ATT, which is usually not something that we usually see, and so would not show weight gain even after successful treatment. Weight gain, if any, happens by the end of 4 weeks. So we have response, which is clinical, fever, cough, weight. Apart from that, we also look at response to therapy in terms of microbiology. And microbiological evaluation, that is who's and whens. So for whom? Microbiological evaluation is done for everybody, that is sputum smear positive, sputum smear negative, extrapulmonary, but more often in sputum smear positive. And what happens to sputum smear negative, extrapulmonary? I'm going to come to it. And when this is something that is being followed up from not from the RNTCP2, but from the NTEM to 2020. It is done at the end of intensive phase as well as continuation phase. And if you have any clinical deterioration or a child who is a TB non-responder, then definitely you need to have a microbiological evaluation of this particular patient. So in sputum positive patients, usually in older children as well as in adolescents with cavitating TB, they are sputum smear positive. And a child who has sputum smear positivity, treated with first-line drugs, sputum smear microscopy must be performed at the completion of intensive phase as well as at the end of continuation phase to say that they're not secreting a lot of bacilli in their sputum. And this is the card which I had shown previously, which doesn't have, which is yet not updated, but updation will definitely be done in the near future. In new patients, if the specimen obtained at the end of intensive phase is smear positive, but the patient is still symptomatic, like I have told you previously, if the child continues to have fever beyond intensive phase or cough beyond intensive phase, we should not only do sputum smear microscopy, but also supplement it with midget as well as NAT. Because if the patient has drug-resistant tuberculosis, we can intervene at this particular juncture and make sure that the child can be started on specific medications accordingly. And in sputum smear negative, recheck a sputum specimen at the end of intensive phase, which has already been discussed. And in case of disease progression due to non-adherence or the drug resistance, error at the time of initial diagnosis. That is, if we have an adolescent who has cavitated tuberculosis and he has come to us as sputum smear negative, and the patient has not undergone a bronchoscopy for a bronchoalveolar lavage, they are usually labeled as sputum negative and started on ETT. And once you start them on treatment, and if you look at their sputum specimen after 2 months, you can actually see that the sputum smear is positive. So those can happen. Sputum smear negative are not done before treatment, and whose sputum smears are negative at 2 months, no further monitoring is actually required, and they are monitored clinically. And most importantly, body weight as well as other clinical parameters are more useful parameters in this particular at this particular juncture. Extrapulmonary tuberculosis, again, clinical monitoring is of utmost importance. Like in this particular child, because this was a child with extrapulmonary tuberculosis, because the sputum, the induced sputum was negative, and we will not be able to do EBUS every time just to document that the lymph node have become negative. So we don't need to do it. And usually, most of these lymph nodes, even though the live bacteria will be dead, but there will be some amount of dead DNA that is there, which will still give us TB, the gene expert to be positive. So going by, now we also look at response to therapy radiologically, usually not required if clinically improving, except at the end of continuation phase. And this is done to make sure that the chest X-ray at the end of therapy is normal, so that we have a baseline chest X-ray to interpret if there is any problem during future course of this particular child, and required only if child is non-responding, slow resolution of symptoms, and deterioration of symptoms. So coming to manage and anticipated clinical progression, what are the usual unanticipated clinical progressions that we usually come across? We have non-responders, drug resistance, which I'm going to come to, tuberculosis, immune reconstitution, inflammatory syndrome, and coexistence. This has been seen in a lot of patients, particularly adolescents and adults. Malignancy, coexistence of lymphomas with malignancies, and children with only mediastinal lymphadenopathy treated as tuberculosis on basis of chest X-ray as well as CT have found to be chronic granulomatous disease in the future course of their illness. So the commonest thing that we usually look at is usual issues in a non-responder. So first question that we usually ask ourselves, if the patient is nearing the intensive phase and still not responding to treatment, continues to have symptoms, is this really tuberculosis? So we have seen a lot of children having a forgotten foreign body in their airways, persistent consolidation, persistent collapse, persistent significant mediastinal lymph nodes, treated as TB, continue to have significant symptoms at intensive phase. Then at this particular juncture, we have to stop ourselves and really look at, are we really thinking about a patient who really has tuberculosis or not? If you have cultures which have already proven tuberculosis, then definitely we start thinking about others. But if you do not have cultures as well as CBNAT, then definitely the diagnosis of TB has to be questioned. Ask and check for correct treatment regimen, appropriate dose, compliance, and adherence to therapy. Most of the non-responders are usually because of this reason, as well as, is this a paradoxical response because of TB iris? Definitely something that has to be considered in a non-responder or a patient who has responded for a short while and again come back with the new symptom. Correct diagnosis, correct treatment regimen, good compliance, still responding, we have to consider drug-resistant tuberculosis. And most of the times non-responders are because of the first three reasons rather than the drug-resistant tuberculosis. Even then, we need to consider drug-resistant tuberculosis. And last but not the least, detect and manage adverse effects. So detect and manage adverse effects, prevention of adverse effects of drugs, isoniazid-induced peripheral neuropathy, specifically in children who have malnutrition, diabetes, chronic liver disease, renal failure. We have to supplement pyridoxine, as was previously described. Pyridoxine has to be included even before you start them on ATT. And monitoring and recording the adverse effects. Most TB patients complete the treatment without any significant adverse drug effects. Only few patients experience adverse drug effects. And most importantly, these patients can be clinically monitored during treatment so that adverse effects can be detected promptly and managed appropriately. Routine laboratory monitoring is not necessary. As previously mentioned, even doing an LFT to start the therapy is currently not being recommended. And LFT just to see what has happened after initiation of therapy, 15 days into therapy, is also now currently not being recommended. So symptom-based approach to managing side effects of anti-TB drugs. So most commonest are anorexia, nausea, abdominal pain. This can be caused by pyrazinamide, rifampicin, isoniazid. But if you have anorexia, nausea, and abdominal pain, you definitely have to look at drug-induced liver toxicity and get a liver function test at this particular juncture. Joint pains because of pyrazinamide, burning numbness or tingling sensation because of isoniazid. And these are characterized as minor side effects. The major side effects are, again, the skin rash without rashes, the jaundice or other causes of jaundice or hepatitis where other causes have been excluded, confusion, visual impairment, shock, purpura, acute renal failure, and decreased urine output. So these are some of the major side effects that has to be kept in mind when we start children on ATT, and has to be told to the parents that if there is any of these sorts of symptoms, please get back to us so that we can monitor this particular child and make sure that no. So a few words about acute ATT-induced liver injury, which is also called as drug-induced liver injury. So a child who started on ATT comes back to you with fever, anorexia, abdominal pain, as well as vomiting. And you do a blood test, you have more than five times upper limit of normal, you have ALP more than 2 times upper limit of normal, and ALT more than 3 times upper limit of normal in children who are symptomatic. You have these two criteria, that is ALP and ALT more than 2 or 3 times upper limit. And in a child who's asymptomatic and still continues to have ALT more than 5 times upper limit of normal and total more than 2 times upper limit of normal, you have to consider, or you have a high index of suspicion of drug-induced liver injury. And with clinical manifestations of nausea, vomiting, anorexia, pain, abdomen, jaundice, and lethargy, you start looking for not only DILI, but also start looking at other parameters or other viral markers which can cause this. So viral infections, specifically hepatitis A, hepatitis C, HBV, HCV, CMV, other autoimmune diseases, biliary diseases have to be looked into. And if all negative, we have to look at the RUCAM classification. And if it satisfies RUCAM classification, we know that this particular child has drug-induced liver injury. And how do we go about? Like I've already presented, absence of symptoms plus ALT, 5 times upper limit of normal, and presence of symptoms with up to ALT of more than 3 times upper limit of normal and total bilirubin more than 2 times upper limit of normal, we have to stop ATT. After stopping ATT, we have to repeat ALT after 7 days, ALT less than 2 times upper limit of normal. We have to start rifampicin. Rifampicin is restarted at maximum dose. And in case if you feel there is a problem and if there is resurgence, please stop. if the child is better and child is continuing to have no problems in terms of repeat ALT being more than less than 2 times upper limit of normal, we can safely restart INH and again repeat ALT after 3 to 7 days, and so we can go on and keep introducing. So in children who have had very severe disease or who continue to have very significant amount of the regimen changes, and we have to make sure that none of the medications have to be introduced. Most importantly, if we have introduced rifampicin and we have introduced INH, we try to introduce pyrazinamide, and if the child worsens in terms of symptoms, then definitely we have to definitely not introduce pyrazinamide again during the course of treatment. So again, the last but not the least, manage treatment interruptions. So reasons for interruptions, that is myth, fears of disease, have to be elevated, and specifically medications. So I have to take so many tablets, such big tablets. Do I really need to take them? What are the side effects of these tablets? Have to be addressed, and every visit has to be taken into consideration to counsel the children as well as the parents that this is going to get the disease better in a matter of 6 months, and please make sure that you continue to take medications even though the child is getting better. So we have interruption up to 4 weeks. That is a patient who has started medications but has recently stopped the medication within 4 weeks. So we resume therapy, restart if missed in the first 4 weeks. At that particular time, we do consider doing a CBNAT if rifampicin resistance not detected, or if the patient has already had a CBNAT, we go on and restart the first line drugs. At this particular juncture, we can also consider LP or DST if the patient has seems to be a non-responder. And interruption for more than 4 weeks, definitely reinvestigate for drug-resistant tuberculosis. If CBNAT is done and it shows rifampicin is not resistant, that is rifampicin is sensitive, at this particular time, definitely we need to supplement with an LPA or DST for INH resistance. And if rifampicin is resistant, then we have to treat them as multi-drug resistant tuberculosis. Thank you.
Srikanta, I think you'll continue the case before Dr. Varinder takes on
Right.
where tuberculosis failed.
Just one request, Srikanta.
Yes, sir.
We have lost a lot of time and I have some other thing to attend to. So if you could be a little fast. Huh? Thank you.
Yes, I'll do this. So going ahead with the case, so this particular patient had good response in the chest X-ray in terms of mediastinal adenopathy getting better, but the right midlobe collapse was persistent. So followed up every month and with good compliance to therapy, came with history of intermittent fever for 3 weeks, developed facial puffiness, neck swelling with venous engorgement on the neck. On presentation to us, febrile, mildly tachypnic with a respiratory rate of 30 per minute with intercostal and subcostal retraction, hemodynamically stable, facial puffiness, neck swelling with venous engorgement on the neck. At this particular juncture also, child had height and weight more than 75% according to IAP growth chart. Systemic examination was otherwise normal. Investigations at this time, patient had CBC with elevated WBCs with neutrophilia, blood cultures, no growth. Other investigations were negative. CRP was slightly on the higher side, 54 milligrams per liter. Again, here induced sputum for AFB was done. Look for possibility of drug-resistant tuberculosis. Because CRP was slightly on the higher side and we're looking at possibility of a secondary infection, we started the child on IV antibiotics and a CT thorax was done. This was the child's thorax where we could see a lot of dilated veins and significant amount of facial puffiness of this particular child. So at this juncture, we have a drug-sensitive tuberculosis with TB mediastinal lymphadenopathy on ETT and an SVC syndrome. And this was the CT of this particular child where we could see superior vena cava becoming significantly narrowed as it goes down to the right atrium. And apart from that, you could see significant amount of mediastinal lymph nodes with a lot of necrosis inside. And at this particular time, the differential diagnosis that we did consider was TB iris. Was it a treatment failure? Was it an MDR TB or a concomitant T cell lymphoblastic lymphoma? So looking at the clinical picture, CT features, it was suggestive of TB iris, and child was started on oral steroids as a rescue measure. Despite on steroids for 2 weeks, child continued to be febrile. So we went ahead and asked for DST on already existing sample, which had proven MTB, and it was sensitive to first-line tubercular drugs. And because this particular child continued to have persistent fever spikes, a decision was made to go ahead with peripheral bronchoscopy and EBUS TB NSR. So, sir, do you, going ahead about drug-resistant tuberculosis, would you still consider drug-resistant tuberculosis? And I would want you to take over now, sir.
Yeah. So here is a child who was a microbiologically diagnosed case, which makes a diagnosis of TB almost certain. And he develops a superior vena cava syndrome. Superior vena cava syndrome, in the absence of a microbiological diagnosis, would have kept our alternative diagnosis higher up, because SVC is more often seen with lymphomas than it is seen with tuberculosis. So that's one point, but it's not that it cannot be seen with tuberculosis, because tuberculosis often heals by fibrosis. And we had in the initial X-ray CT scan seen a huge lymph nodal mass, which was what Dr. Subramania also alluded to in his talk on radiology, that the mediastinal part can be fully hidden. So we did not see as much on the X-ray as we actually found on the CT. So therein lies the value of CT in these type of cases. Now, when a child on treatment does not respond and your diagnosis is TB, like in this case, then one has to again confirm a few things. One is that, was the child adherent to therapy? If was adherent to therapy, then was it that this child was getting the right dose, right combination? If that is true, then drug resistance TB remains an important possibility. So the effort which was made to refine a sample in this case, because drug resistance TB cannot be treated by repeated same set of antibiotics if the child is not responding and spiking, was absolutely correct. More so because this child at this point of time was having fever or was symptomatic. It was just compression symptoms. Then you could have taken a different course. So with that, let me take you to where and how you would think of tuberculosis or a drug resistance to tuberculosis. We leave this patient for a while, and just give me one moment. I need to put a charger to my laptop.
In the meanwhile, Subramania, can you answer that question about if a suspected disseminated TB, skin lesions showed to be AFB? What do you... Unmute.
I think if there is a miliary spread, sir has come back. I think.
Yeah.
Okay.
You want me to continue, or you're discussing something?
Continue.
Okay. So, are there any clinical footprints to say it is a drug-resistant TB? Can we identify? There are no footprints one can identify. In the adult studies, it has been said that maybe if you have a cavitary TB, more likely. But then more likely, it doesn't ascertain that it is there in your patient. So you have to find the giant. You have to find the bacteria and show that it is resistant. When do you suspect clinically? As it's a bacteriological diagnosis, it can come upfront to you because now we are doing universal DST. Clinicians often would consider a patient who is not responding to therapy failing, where clinical signs persist or recur, like in this case, or have poor radiological or clinical improvement or deterioration, particularly if there was a contact of proven MDR case. But remember, this history may not always come. And an older child may have a contact outside household, which was very nicely elaborated by Dr. Subramanian. So possible reasons for non-response could be, as I said, drugs, wrong dosage, irrational combination, or poor adherence. Remember, a child visiting you each time is not necessarily an evidence of adherence. Children can swallow, spit, not take, dislike one drug, all of that is possible. Mothers who say that I've been giving right dosage. So often our questions are with answers which are in binary. Are you taking your medications? Yes. Are you taking them as I have told you? Yes. Is no question and no answer asked. What is the medication you are taking? Show me. How much is the dose you are consuming? Show me. And then see, is it the same as what you were giving? I have had situations where somebody was giving a liver tonic which the doctor had prescribed, which was in a capsule, hoping that it will decrease the hepatotoxicity, and not giving rifampicin because they thought that was more important than the other one. The liver should stay strong because doctor had told them this could cause jaundice. And they omitted rifampicin from it. So there can be several ways this adherence or compliance can be affected, and that needs to be looked into. One thing which we often do not consider in a non-responses diagnosis not being TB at all. In the index case we are discussing, it was microbiological diagnosis. So that's not the question. But in a clinically diagnosed case, if you have a non-response, review your diagnosis. It's quite possible you started with a non-TB and started on a therapy and child would not respond. However, if it is TB and it is not responding, then it could be because of drug resistance. If the symptoms are recurred, they could also be because of a comorbidity or another infection. God doesn't give you a guarantee that if you are suffering from TB, you cannot have malaria, you cannot have typhoid, you cannot have a pneumonia. You can have any of these. So therefore, those infections which has temporarily ended at the same simultaneously are also possible. Sometimes our body reaction is beyond healing and it paradoxically goes overboard, and that is what we call as a paradoxical reaction. But this is a diagnosis of exclusion because it does not have a diagnostic criteria. You have to rule out all of above. If none of that is present, it is TB, it is you're using the right drugs, patient is not responding, then one reason could be a paradoxical reaction. So your presumed cases would come from non-response to first-line therapy, or from an interrupter, or from a relapse, or from others who have been in contact of MDR or CLHA, as was mentioned by Dr. Srikanta. We know with modern therapy, fever and cough usually goes down in about most of your patients, 80 to 90%, it should have gone down by 4 weeks. Here is this patient who did not. The cough can take longer, little longer. So about 80% by 4 weeks because airway compression may happen. But most of the other things, appetite loss, fever, they improve very fast. So that's something very important to remember. One thing which we also sometimes look at is the weight gain. TB drugs are not obesogenic. You gain weight on TB treatment if only you had lost in the process of developing TB. Otherwise, you gain only as much weight as a normal child would gain. So remember, weight gain, it comes with the context or with the caveat, and the caveat being that you gain extra weight if only you had lost, because that's the recovery. If you look at the radiological improvement, the radiological improvement in first 1 or 2 months is very poor. Not more than 10% of the cases would have any improvement at 1 month, or significant improvement is less than 30% even at the end of 2 months. In another study which we had done, the primary complex or progressive disease at the end of 2 months, again same picture. Pleural effusion much less, 50%. But if you look at it, if 6 months, most of them would have clearance. Less than 10% of the pleural effusion stays, less than 20% of the hilar lymph nodes stay, and inhomogeneous opacities may, because of the scarring or a collapse, leaving a bronchiectasis, may leave shadows even in about a third of a case. So X-ray is a very poor, or for that matter even CT is a very poor marker of resolution. It gives you a clue. Ultimately, it's the bug which you have to find to say whether it is responding to therapy or not. And therefore, I am in agreement with what Srikanta has presented, that perhaps this child required a revisit for whether this child was drug resistant. Would I have gone, if you do not have EBUS available to you, would you refer this patient always for a EBUS? Perhaps not. This child who has such a large lymph node may have a bronchial disease. You go in, do a BAL. In the earlier situation, also MJ had come positive. So you do a BAL. The BAL may give you an answer. EBUS may not be possible in a very small child because EBUS bronchoscopes are huge. So if this child was 3 or 4 or 5 years, EBUS may not be possible. So, or it may not be available in your city. So that's not important. Review with whatever is there is important. If this was not responding, even after your repeat effort to find a bacteria had failed, and it was feasible to do further testing, yes, go all out. Then you have to refer this child because you may have an alternative diagnosis which is lurking in the back. Less likely in this case because it was a microbiological case, but you may definitely have a reason to suspect resistance because it's a failure to therapy. So the methodology which was used is what anybody, which is recommended and which is how it should have been done. So MDR TB or drug resistance TB, apart from these situations, you should consider when on history, you find a history of contact with an MDR TB case in the family. Remember, often you may get a proxy marker, and the proxy marker may death due to TB. Death due to TB in an adult is not so common if they are on adequate therapy, and drug resistance TB is one of the important causes for increased mortality. So if you have a patient who comes to you and if somebody in the family has recently died of TB, consider drug resistance as an important possibility. HIV positivity is another thing which you should have to keep in mind, but it is always what you need is microbiological confirmation. If you do not have the facilities, if you are in a smaller area, it may be worthwhile involving district and nodal DRTB center of the government, because MDR-TB as it is difficult to treat. The drugs are expensive, and all these are available free of cost from the program, and it benefits referring this patient for a shared care. They get their medicines from there. You follow up them for adverse events. You follow them up for response. Keep a tab on this child and other things like immunization, growth, feeding, which will not happen under the TB care. So let TB care be provision of drugs. You monitor the rest of the things in the patient, and that would be more holistic care for your child. What are the tests we prefer? We always prefer NAT. It could be expert or true NAT because it has a very fast turnaround time. If this is a smear positive case, you can even get a first line LPA. In this child, because you are considering drug resistance, you will go beyond. If this turns out to be RIF sensitive, then it could have been an INH resistance. I remember I was told by Shrikant that this patient had drug sensitive TB. And I understand on a repeat testing also, it was sensitive to all first line drugs. If that is not the case, then you would, if none of these work, you will have to go for culture. On culture isolation, you would get an LPA. Remember, these tests, as Dr. Subramania had showed, do not have high sensitivity in pediatric TB, more so in nodal TB. So they may not be positive in about 30, 40% or 50% of cases. And therefore, you may have to resort to culture. Even that may not be always possible, but that's what you need. When you use culture, the isolate, if you test this drug sensitivity by molecular method called line probe assay, it decreases the total time because phenotypic DST will take longer. So that's how we use a mix of tests for identifying drug resistance. INH resistance would have been an important confounder in this child or a possibility in this child because this child had to begin with come with RIF sensitivity and had relapsed. And Shrikanta did the right thing, asking for drug sensitivity to first line on the initial sample, and that turned out to be positive, showing that child was INH sensitive. So that's another thing which was important and was well done in this case. Quickly, some definitions which come up your way. Monoresistance is resistant to any first line therapy other than R. When we have rifampicin resistance, we consider this as a marker of MDR-TB because almost always, even though you don't test it, it comes with an existing INH resistance. If you have proven the resistance to both INH and R, then it is MDR-TB. But in a case which is H and R resistance, you also have resistance to fluoroquinolone or a second-line injectable, then it is called a pre-XDR TB. If you have a combination of resistance to everything other than R and H, then it is called polyresistance. So multi is a term which you use for H and R. Poly is a term you use for more than one resistance, but which does not include H and R. Pre-XDR is what you use when you have MDR, which is H and R, plus either a fluoroquinolone or a second line. So these are the terminologies which are important. XDR is a term which is now going out because we have newer drugs. But earlier, when there were very limited, we had limited drugs. So if you had resistance to both fluoroquinolone and its SLIs, then it was extreme drug resistance, and some people even called it TDR, or a total drug resistance, which is a misnomer, because you do not know what all drugs are available to us, which we do not know, and the drug may be sensitive, the bacilli may be sensitive. Remember, there is a situation that despite all your efforts, you will not get the bacilli. So then you may end up in a situation which is a probable MDR case. The probable MDR case is a case who has clinical non-response with or without radiological deterioration, despite adherence to ATD by the end of 4 weeks, with at least one of the following risk factors, which is exposure to an MDR TB case, death of a case due to TB, or loss to follow-up, and you have attempted and the microbiological tests have come negative for MTB. You are just not able to isolate MTB. It is not that you have been able to isolate MTB and it is sensitive to drug, then it is not a probable MDR case. Then you have to find other causes for this child not responding. Is there an associated immune deficiency? Is there something else? Is it a chronic diarrhea or a CLHA? Dr. Mayur, if you can mute yourself, I'll be able to speak. Thank you. So this may be a case where you may have a CLHA or a non-absorption. There you may have to do a therapeutic drug monitoring, not so easily available. So you have, or it may be an extrapulmonary situation where you do not have access to specimen. Then we may have to treat them as a probable case. This is absolutely desperate. You don't do it routinely, probable MDR diagnosis, because the second line drugs are very toxic. However, there are a very small proportions where you may have to resort to this diagnosis. If you think of MDR, there is a huge gamut of investigation which you require before starting treatment, because you need KFTs, LFTs, electrolytes, because many of these drugs prolong QT and can cause certain death. Therefore, you need to see the magnesium levels are normal, calcium levels are normal, serum proteins are normal. For if you're going to use a delaminate, if you're using a PAS, the thyroid function needs to be tested. If you're using SLI, audiometry needs to be done. So there is a huge set of investigations which are required for a pre-treatment evaluation. So once you have got a case of RRTB, then you have to look at second-hand LPA to ensure that this ref-resistant TB is only MDR and not a pre-XDR. It is sensitive to a fluoroquinolone or SLI, because that is how you will decide what drugs you give. If it is ref-sensitive TB and not responding, then you are going to evaluate for H. If it turns out to be H resistance, the story doesn't end here, because these alternative drugs are weakened if there is a problem with fluoroquinolone resistance or pyrazinamide resistance. Areas like Bombay have a high fluoroquinolone resistance in the background. So with there, you want to see this H resistance is not also fluoroquinolone resistance or has a pyrazinamide resistance. So unlike in the past, where we were using standardized therapy for drug sensitivity, now we are not even talking of standardized therapy for ref-resistant or MDR. You go upfront and diagnose to possibility of resistance for others, and the rapid molecular methods have made it possible, or a hybrid method of MJIT followed by an LP has made it possible for us. And therefore, there is a need for further investigation to know what all is possible. If you know your patient is not resistant to SLI and fluoroquinolone and it is just pulmonary, then you can use a shortened regime consisting of high-dose moxifloxacin, kanamycin, ethinomycin, clofazimine, along with high-dose INH, pyrazinamide, and methambutol. After 4 months, if there is delayed response, you can go up to 6 months, and then followed up with a continuation phase of moxiflox, clofazimine, pyrazinamide, and ethambutol. So you stop primarily the injectable and ethinomide, and you continue and the high dose INH. If this child was above 6 years, then you have a benefit of using newer drugs like delaminate. You may even start getting bedoquilin in a short while. Currently, it is recommended 18 years, but it may come down to about 12 years of age in our country. We are hoping worldwide the recognition is for 6 years, but the DCGI approval has not been taken by the company for above 6 years for bedoquilin. So you may have either delaminate or bedoquilin containing regimes coming your way, and then you can do away with injectables which are so hard to give, and you have an all oral regime which is available. However, these newer drugs have not been tested for disseminated and extrapulmonary disease. When you use a combination of these as a conventional regime, or you may use amikacin with high dose moxifloxacin linezolid. The short-term regime which I had shown above is also not recommended for a disseminated or severe extrapulmonary. So this shortened regime, injectable, which is given below 6 years, is available only for pulmonary cases or lymph node or pleural effusion. If you are disseminated, you go for a long-term regime. If it is above 6 years and pulmonary, same as this, you can give for all oral. If it is above, again, disseminated above 6 years, you still have to go back to the longer regime. Here again, modification will be done based on additional resistance pattern, and I had shown you what all you need to do. If you have INH resistance alone, then while you are testing for fluoroquinolone resistance and pyrazinamide, you put on 6 months of levofloxacin, R, E, and Z. So this is a uniphasic regime. This may be extended to 9 to 12 months if it is excessive pulmonary disease or a bone or an intracranial disease, in which case you have to use long-term as you use in a case with drug resistance. I'm not going to take you through the dosage of drug resistance because they're huge, too many, but they're important that we should know. Keep a chart like this handy to you because this is something you would need. Duration, as I've told you, depending on the regime this child will follow, will depend between 12 months to up to 18 to 20 months. And that's why it is important that they are under a shared care. It's a very expensive regime and you need. But if you come to case Shrikanta had, Shrikanta, do you want to add anything more in your case or can I go ahead with the PUR? Shrikanta?
Just a couple of slides, sir.
Yeah, please go ahead, then I'll stop sharing. So let's hear from Shrikanta what happened in his case when they did repeat EBUS.
Yeah, so because this was a case where everything was done and we were pushed to the wall, and despite starting on steroids, continued to have persistent fever spikes, a decision was made to go ahead with repeat EBUS, repeat bronchoscopy and EBUS. And bronchoscopy again, bronchoscopy with EBUS showed Gram-Stain had no gram-positive or negative organisms. AFB stain, no AFB smears, AFB organism scenes. Gene expert was negative. TBNA aerobic culture as well as TBNA aerobic culture was no growth. Histopathology as well as core biopsy showed acute necrotizing lymphadenitis, suggestive of tuberculosis, immune reconstitution, inflammatory syndrome. Sir. So yes, again, reiterating that TB iris is more of a clinical diagnosis rather than a definitive diagnostic modality, which is not available. And secondly, this particular child underwent a EBUS only because repeat EBUS and bronchoscopy only because despite starting on steroids, child still continued to have persistent symptoms, wherein we had to find out what we were doing here with, was this drug resistant TB or was this concomitant or coexisting lymphoma which we had missed out. So that's the reason why we did a repeat EBUS. So to you, sir.
Thanks, Shrikant. So what we came to was that this child had sensitive TB even now, and this was perhaps something what is called as a paradoxical upgrading response. What is a paradoxical upgrading response? It refers to enlargement of old lesions or unexpected appearance of new lesions during apparently adequate anti-tuberculous therapy. We decided that ATT given to this patient was adequate, because we have time and again proven that the sensitivity was there for the drugs on which this child was, and obviously the adherence and the dose would have been looked into, and the combination would have been. It can happen at any time, usually within 3 to 12 weeks of beginning therapy, but it can even happen later. Generally is self-limiting, resolves without serious sequelae, and does not require much intervention, and can regress without a change of initial drug regimen, but sometimes it requires prolonged. Various type of paradoxical responses have been reported. It can be an increase in size of mediastinal node, as was in the index case. It could show appearance of a pulmonary infiltration in a patient who primarily started with node, development of new lymph nodes elsewhere, or enlargement of the original nodes, development of new pulmonary infiltrates, and development of pleural effusion in a case where it did not start with a pleural effusion. It can even be contralateral. There can be increase in number and size of tuberculoma within the brain. There can be a CSF showing pleocytosis. In a lymph node, there can be enlargement of the peripheral lymph node, new nodes, discharging sinus, which is because of the retained caesium which is being there. The lung, there can be a perforated viscus. So why does it happen? It happens because the active TB results in a depression, localized depression of immunity. So when you start anti-TB therapy, the focal immune response improves. And there is an accumulation of inflammatory exudates at the previously invisible microscopic foci elsewhere. So we are looking at one lesion, assuming that disease was localized here. That may not be truly the case. There were several other lesions which at this time had not caught your eye because they were not large enough to be picked up by the X-ray or by the CT scan. The increased sensitivity Dr. Subramania referred to in CT is also that you will pick up some more lesions. So these kind of things happen, and those are the areas where the focal response may be higher, and these may develop. Oh, a new lesion has come. The difficulty is, if it is drug resistance, a new lesion can appear in a new area because of drug resistance. So you can't differentiate between the two till you have ruled out drug resistance, which was very nicely done in the index case. And that is why the take-home message here is, remember, PUR is a diagnosis of exclusion. It does happen, may happen more often than drug resistance, but you have to rule out drug resistance, because if you miss drug resistance, then the outcomes are going to be much worse. And it is damage not only to the patient, but also to the community if this happens, because it's an infectious disease. And he may spread it to, even a child can spread to others, depending on the cough and the communication of the lesion with the airway. It depends on that. So how do we know what I'm saying? Let me show you quickly one case, which was a big learning for me. There is a child who had chronic symptoms, developed a swelling over sternum, which was AFB positive. And this is of an era when we did not have any of the new tests available. So this is a bit old case, but still makes the same point. It's a 100-year-old disease, which we are still learning about. It's not corona, it's not COVID, where we are learning every day. It's a disease where we learned over 100 years, yet there's more to learn. This child was put on ATT. Somebody decided to do a detailed MRI. Don't ask me why. It was done. This child also had back pain. His plain X-ray of the back was normal. When they did MRI, they found that this child had huge lymphadenopathy, which was not seen on this X-ray, which you had here, except for a hilar lymphadenopathy. Had involvement of the sternum. The sternum was AFB positive, so there was no need for a detailed MRI because we had found a lesion here. However, it also showed a paravertebral abscess with a vertebral involvement, with this child's plain X-ray being absolutely normal. If this chance MRI was not done, we would not have noticed whether there was a disease. And lo and behold, somewhere down the line, 2 months into the therapy, he develops a cold abscess over the back. If this MRI was not done, we would have said, oh, there is a new lesion at a new site, drug resistance. Now we know this was most likely a paradoxical increase of a site which we had not identified earlier because we had not looked for it, because there was no reason to look for it. So this was a learning by serendipity, okay? But this tells us whatever theoretically I've been telling you had a basis. We had a case from where we could learn. And most of the time, when you see a bend in the road, which is a change in inflection in your diagnosis, It is not an end point. Oh, it is drug resistance. It may just be a bend in the road where there may be other opportunities. There may be other diagnoses waiting. Like in this case, we had paradoxical upgrading reaction. So remember, when a child does not respond to TB, it could be wrong diagnosis. It is not TB. It could be poor drugs, poor dosages. It could be drug resistance. It could be a paradoxical upgrading reaction. It could be a co-infection. Keep all of this in mind. This is the carry home message for you. Remember, all these possibilities exist in every case. You do not need EBUS in every case. You definitely need an EBUS. When you have a back to the wall, you have tried all sensitivity and you are not getting a diagnosis. So scaling up where you refer your patient depends on the characteristics of your case. It doesn't mean it has to be done. Every child of lymph node which you see, you have to go and prove. You can hold on, make all efforts to get a microbiological diagnosis. You don't get it, treat. If this fails at 4 weeks, go ahead, go all out to get to a final diagnosis. That's where I stop. Dr. Jason, over to you.
Yeah, so we have a few questions. The first one to Dr. Varinder Singh is, if you have a rifampicin sensitive tuberculosis, how many of them will later become drug resistant? You know, how often do you see that?
Highly unlikely, not many. This happens usually in a case where there may have been a mixed population, which is usually not the case in pediatrics. However, this can happen with inadequate therapy. A RIF-sensitive case becomes RIF resistance only if there is prolonged inadequate therapy, not otherwise.
Second question to you, sir, is this contact with the drug-resistant tuberculosis. Children contact with drug. What is their prognosis? I mean, how many of them will develop disease, and what is the? Yeah. What's your CDs? Do you have any CDs in mind?
No, I don't have a series on this, but the world experience shows that your body does not differentiate between drug resistance and drug sensitive. That is why you do not have a footprint on how it will come. You can have just a lymph node, it can heal. So a drug resistant TB has as much possibility of natural healing as a drug sensitive TB. So all contacts of drug resistant TB will not necessarily develop disease. That's for sure. Any child who's in contact, you give preventive therapy. So for drug sensitive, we know preventive therapy is 6-INH, you give it because there is higher risk. In drug resistance case, we do not have an established therapy. You have some options of a fluoroquinolone therapy being used. But in India, background fluoroquine resistance is so high that you would not endeavor giving a fluoroquine prophylaxis to a child who is in contact with a RIF resistance case. So therefore, this is an area where we prefer to follow up if there is extensively. And if you find any early signs of appearance of disease, you work up and treat accordingly.
The next question is, what's the latest you've seen TB iris?
Sorry?
The latest you've seen a TB iris.
What is
the
it?
TB iris. Now, this time you had a TB iris 5 months into treatment.
Yeah.
After it was well for 5 months.
How late?
What's the latest you've seen?
How late I've seen? Oh, yes, if you would call a discharging sinus or an increased lymph node in the neck, I've seen it as late as up to a year after therapy. But then if it is so long after, it becomes very hard to say whether it is a relapse or it is just the same node which is appearing. If there are any constitutional symptoms, I will retreat based on whether it is RIF sensitive or RIF resistance. If it is early on and after expression of caesium, it goes away, I would not. So I would say, don't look at the length. Every child merits a re-investigation for the cause of that sinus. You may have a relapse coming within 3 months. You may not have a relapse at 1 year post-therapy.
Dr. Vijay Evle, there's a question to you. How do you ensure compliance? What is the methods that is used to ensure that there's compliance?
Dr. Jason, I really have an emergency. I need to leave. Would you allow me? Then
thank you so much. We've enjoyed having you. It's been a great pleasure. Everyone just was wanting to listen to you. Thank you so much for that detail.
I have few calls to attend to from my hospital, and we are a COVID hospital, so I can't. I have been holding them for a few hours.
Thank you so much, sir. Thank you so
Thank
much.
you very much. Thank you very much.
Jason, coming to your question, how do you ensure compliance? I think Dr. Varinder Singh and both Shrikanta alluded to it, but the best, how we do it in practice is first and foremost, you write down the plan of treatment, explain to the parents well with the medicines that what he has to take, when he has to take, when the child has to take medicines, and call him for follow-up. The first follow-up, as both said, is at 2 weeks, though the program is not calling them at follow-up at 2 weeks. The first follow-up is just to really look into if the child and the parents have understood your instructions or not, and then you actually ask the pill count, the color of the urine. That is one thing that is important. And then just don't say bacha dawa le raha hai kya, whether the child is taking or not. Go into little details. That's the only way one can ensure that good compliance. And that is why I said we must try and refer all these patients to the program, because they have a dedicated team, and first of all, the drugs are given on weekly and monthly basis, and if the child or the parents don't report to the program, there is a active follow-up done, and the parents are interviewed and questioned why the parents have not turned up to correct the remaining drug. They are also starting one is DOTS, where a family member is made responsible, or a treating practitioner. A practitioner can become a DOTS provider. That can be done. And they are also starting a system where electronic media will be used. Every time child takes a pill, there is a message, text message which goes, and then it is recorded electronically. Though it is still in next stage, and it is not used all across the country. And this all what is being planned, and this is how one would ensure that compliance is. And then, of course, you follow up clinically whether the child is improving or not, keeping in mind all these possibilities, that poor adherence, iris, and drug resistance. And then you evaluate the child according to what the child falls into.
Dr. Subramania, there's a question on HIV and tuberculosis. What is your any experience on HIV and tuberculosis?
If you ask me personal experiences, we would institutionalize them and manage. Point number one. And we need to understand that ART and ATT, there is some amount of drug interaction, and therefore treat tuberculosis, and after a couple of weeks, you can start ART. But now the current trend is to introduce ART little earlier. However, if the child is if it is a child known to be on HIV and then develops tuberculosis, it does not mean that just it has come in contact with tuberculosis. It also means that its HIV status may be worsening. For example, if you go down the immunity, then you will have, I'm just telling you, go reverse of this iris, so therefore you may have the expression of the disease. So therefore, a jugalbandi of ART with ATT, and establishing the correct diagnosis, monitoring the status, and it's really a nightmare to manage that patient. So far in my experience, I had only one patient in whom I had to manage HIV with tuberculosis. Both parent, one of the father was positive and mother was positive, and the child had really retinopathy also. It was blind, and it had tuberculosis. This is what I could recollect. Not many cases I had handled. And Dr. Vijay Avale, maybe from that area of Mumbai, from where a lot of HIV cases would flow. In Bangalore, relatively less. This is my input. Personally, if you are asking me, as per guidelines, for a practitioner, such cases should be just institutionalized.
Yeah, one more point to add, Subramania, what you said is absolutely right. But at the end of completion of therapy, you again put these children on INH prophylaxis for another 6 months, like you do for latent TB.
INH prophylaxis has to be continued.
Continue for 6 months after completion of therapy. Yeah.
I had a question from the chat box, which I felt very relevant. What will you do if you get only MAN2 positive? Somebody has asked me, and I would respond. If you get only MAN2 positive, there are two options for you. Is the child symptomatic or asymptomatic? If it is asymptomatic, then it could be latent tubercular infection. If the child is symptomatic, that means running fever or anything, please look for extra pulmonary tuberculosis. That's very, very important. Here you may have to do ultrasound, not just ultrasound, you may have to really explore. Ultrasound is again dependent on abdomen. I'm just telling, look for abdomen, look for hidden areas. Really you have to go like a good search for finding the focus. But if the child is symptomatic and if the symptoms are coinciding with the Manto positivity, please understand. Somebody getting an URTI viral fever and is Manto positive, please do not bother. Wait for the fever to go. When I say symptomatic, I mean to say again fever of 2 weeks. Really the fever should bother you. Just presence of fever and Manto positivity, please don't do. And do not repeat Manto. Do not repeat in the other arm. It is not going to give anything. And lastly, do not repeat Manto after the treatment. Because there is no sense. It doesn't add any value. You don't expect the Manto to return back to normal. And on the similar lines, please, at least it should become an obsolete test. Now we have a CTB which is coming up right now. It's not there in India. And IGRA antigens can be given in replacement of the existing the reagents for the Manto, and we will be having newer BCG, newer Manto, and everything fine. But basically, it is a clinician at the back of the patient who should really go through the clinical profile, calendar of events, origin, duration, and progress of the events in that particular child and the pathophysiology, correlating with evaluation and investigation timeline. They should match. That's the skill that an individual pediatrician has to exercise.
Sorry, sir, to cut you off, but then we have already exited the time limit, and anytime the link can go off. So I would request Dr. Johnny, our secretary, to propose a word of thanks.
So on behalf of Pachna, sorry, so is there anything more? So shall I go ahead?
So on very brief, please.
Yeah, on behalf of Pachna AAP, I thank you all the audience who participated, and also the brilliant speakers, Professor Varinder Singh, Dr. Subramania, and Dr. Vijaya Yavel, and Dr. Srikanth for their brilliant speech, which demystified the complexity of pediatric tuberculosis. It was really, an academic feast. So we are looking forward to such meetings again, and also thank all the PGs and all the senior delegates who have attended. Unfortunately, we could not do the quiz this time, but we'll definitely come up with the